There we go. So, why don't we just kick it off here? We've got a good group started, and I expect we'll probably have more joining. Um, let's uh, let's start off with you, Julie.
Okay, great. Can I share my screen just by hitting this share button?
Let's wait first. Let's go through the
Okay.
group, and so you kind of know who's around the
Oh,
table
perfect.
and who your audience is. So, but go ahead,
Wonderful.
introduce yourself.
Great. Yeah, I'm Julie Dusold Culbertson. Thank you so much for having me. It's been about 10 years since I've been in with the Digital Drive Health Innovation team. I left the federal government, the Oversight Agency for Health and Human Services, about 10 years ago. So I'm delighted to be back here and excited to talk with all of you about the Trustery and the sort of portal that I've been dreaming about for a couple of years now and hoping to bring into existence. So I look forward to your feedback. Thanks so much.
Yeah, it's great to have you, Julie. Jason.
Jason White. I'm with Mid-America Regional Council. I'm in emergency services, and I'll be talking through some community paramedic stuff. So thanks for having me.
Mm-hmm. Amy.
Hi, everybody. Amy Teskey. I am in Kansas City here, and I have a health IT sales community, individual contributors and leaders in this space. And then I do growth advisory as well. So glad to be here. Looking forward to it.
Great, thank you. Anurag.
Like in the chat, John, he can't come
Oh,
off mic.
okay, I see. Thank you. I appreciate that, Kat. Britt.
Hi, I'm Britt Shanklin. I'm serving as AmeriCorps Vista with KC Digital Drive.
Great. Deb Cisco.
Morning, everybody. I'm Deb Cisco. I'm the manager for patient advocacy and engagement at University Health. Happy to
Great.
be here.
Great. Let me see. Dan English.
Sorry, I'm late, everybody. Dan English, project coordinator, cancer research coordinator, jack of all trades at the KU School of Nursing.
Great. Evelyn.
Good morning. I'm Evelyn Nelson. I'm a child psychologist at KU Pediatrics, and I also lead several telehealth grants.
Great. Dr. Castro.
I'm a ER board certified doctor for doing it for about 20 years, and I have my own AI and healthcare company as an advisor for Singapore and the Texas Medical Association.
Great, thanks. Which Jim do we have? Do we have Jim Starso?
We do have Jim Sarso. I'm Jim Sarso. I'm part of the KC Digital Drive team.
Great. Josh.
Hey, good morning, everybody. Josh Weimer, Chief Health Information Data Strategy for Missouri Health and Senior Services. I did just want to comment. We had a great budget hearing yesterday, and today is the confirmation hearing for our new director, Sarah Wilson.
Great. And I've noticed that the report has come out, and that's for a data modernization for DHSS, and that's available on the GHSS webpage. Is that right, Josh?
Correct. Yes. So our data landscape survey, maturity evaluation, and strategic assessment is now available at health.mo.gov/data. And apologies, I've got a junior board member I'm dropping off at her school day in the background.
Okay, that's fine. Thanks. Kat.
Hi, I'm Kat. It's this recent graduate with a doctorate in public health from the University of Illinois, Chicago, and I'm here at the Mid-America Heart Institute as an outcomes research scientist.
Great. Kevin.
Hi, I'm Kevin Mills. I am the president and CEO of BioKansas and at AstroBio, the trade association representing life sciences and healthcare in Kansas.
Great. Welcome, Kevin. Lisa.
Good morning. This is my first time attending a meeting. I'm super excited to be here. I'm the finance director for the Lewis and Clark Information Exchange. We're an information exchange that covers both Kansas and Missouri, and anxious to learn more about the presentations.
Well, you're very welcome. Happy to have you. Liz.
Hey, everybody. This is Liz Schaefer. I'm the program director with Digital Health KC, which is a nonprofit here in Kansas City that is focused on growing our digital health ecosystem and supporting our early stage and entrepreneurial pursuits here. Thank you.
Great. Robert.
Hi, I'm Robert Stiles. I'm the director of Telehealth Rocks, which is a two-state Missouri and Kansas initiative with local and state and national partners that really focuses on using telehealth and teletraining and other approaches to meeting community healthcare needs.
Great. Robin.
Good morning, everyone. I'm Robin Johnson, Impact Strategist for Health Forward, a part of the people team with the whole person care.
Great. Welcome. Sherry.
Greetings, everyone. I'm a maternal health advocate and a community health worker.
Okay. Stan.
I'm muted. I'm Stan Heathervich. Have adjunct appointments at both medical schools, and my interest has been pharmaceutical safety, but most recently I'm starting to get into the whole area of genomics and where our field should be moving to contribute as epidemiologist. I'm an epidemiologist.
Great. Thanks, Stan. Tish.
Hi, I'm Tish Bryant with the Missouri Primary Care Association. I'm the Community Integration and SDOH Coordinator.
Great. Tracy. Tracy, are you with us?
Yes.
Okay.
Hi.
Hi.
I'm Tracy Bentley. I am a board certified patient advocate and yeah, with
Okay. I'm sorry, with whom?
Tracy for Patients.
Okay, very good. Sounds good. Is there anybody that I've missed? It looks like Marlene is with us. Marlene?
Hi, good morning. Marlene Nagel with Mid-America Regional Council.
Thank you. Jules?
Yeah. That's me.
Oh, that's you. All right. I'm sorry. Yes. And Doug.
Yeah, and so Doug, I'm a AI consultant focusing on healthcare and policy, and I am now on the AI KC AI Club board, focusing the humanities chair, focusing on AI's impact on humanity, society, and our local community. And I'll post in a couple things in the AI Club that we're having in recent events that on job and AI, and also on the society and AI that's coming up.
Sounds great, Doug. Thanks. Anyone else that I've missed?
Hey, John. A little late to the game.
That's okay. Welcome, Dennis.
Dennis Ridenauer, CEO at BioNexus KC. We're a nonprofit here based in Kansas City, focused on the region between Columbia and Manhattan and advancing life science and healthcare innovation. So,
And
thanks, John.
still celebrating Valentine's Day.
Yeah, I don't take credit for the wonderful decorations when they go up. I also do not take credit for them when they go down, but they will be coming down this week, probably.
Okay, well, we're looking forward to St. Patrick's Day then.
Yes, that's what's going to come next. So
okay, sounds great. Okay, well, let us begin with Julie. We got to know Julie early on in the health innovation team space. She had been with the Inspector General's office for Health and Human Services in District 7 here for HHS, and has gone on to do other remarkable things. And I'd like her to say a little bit more about her background and tell us about what she's trying to conceive and bring to reality. Julie?
Thank you so much. Let me try to pull up my little website here. Yeah. Let's do it. Oh gosh, this is a lot. Let's see if I
sweet.
can minimize this.
We
Is that
see it.
better?
Yeah, we see it.
That's good. Okay. So I have a nonprofit here in the Kansas City area that most of you probably have not heard of because we haven't been doing terribly much to promote it, called the Trustery. And it was born when my own, let's see, 4-year-old at the time, 4 or 5-year-old, developed really debilitating school anxiety where her teachers had to pry her off of my body, crying every morning on the way to school. I found out that my old college roommate, my undergrad roomie, was teaching something called youth mental health first aid, which some of you might be familiar with. It's actually an international program that's sort of like CPR for mental health. That's the idea anyway, that you're training people to know what to do in a crisis situation. There's a 5-step sort of plan to evaluate what's going on and figure out next steps. And it's a great program. I benefited a lot from it. Decided that I wanted to also be able to teach it. We created this nonprofit around it. And as we were teaching youth mental health first aid, we realized that it's a really great program for people like teachers or other people who work with children in the community, but parents don't have the 6 to 8 hour chunk of time to just drop everything and attend a session like that. So we tried via our nonprofit to create more palatable ways for parents to get some of the most essential information about youth mental health so that they could help the young people in their lives. So we have a little, what we call mental health mixer or mingle kind of guided workshop where people can just take this information into their backyard with their friends and talk about their own mental health issues, about how they were parented, and kind of bust some myths around how to talk to kids about mental health. We also go into schools, parent-teacher associations, and have a more palatable, 1 hour long kind of caregiver essentials program where we can talk with people and give them the list of local resources that we have for them, crowdsourced practitioners that have been helpful for people with different conditions of varying ages. Because we found as we've been doing this work, people really need resources in terms of where to go when they realize that there is a problem. When I was dealing with my child, as I was talking about her school anxiety, the pediatrician just handed me this PDF of like 20 psychologists locally that theoretically would see children. Not any information about whether they would see my children at that young age, whether they took my insurance, whether they were taking new patients, whether there was a 6 or 8 month wait to see them. So I kind of just had to, find time in my day to get on the phone and start calling everyone one by one to see who would even see my child. I waited several months to get into an appointment. And that's the step where, a lot of parents find this person that they've been waiting months to see just blows them off and wants to write a script and not answer any of their questions. So we're seeing some real pain points with parents trying to get the information that they need to help their children. And we wanted to create this web portal that had crowdsourced information about what kind of practitioners have actually been helpful for other people with lived experience, children going through anxiety, depression, suicidal ideation, whatever it might be. And these practitioners are actually helpful for me. They see kids this age, start with them, right? And then also give them little kind of micro lessons if all they want to know is about school anxiety and not, fall down the rabbit hole of things that they're finding on the internet. Just give them a little evidence-based, 2-minute audio track that they can take in their car or a little video that they can watch to sort of understand what's going on, what they can expect at an appointment with a practitioner, when they definitely need to seek help, other kinds of resources that we can point them to. The problem is we didn't want to have to charge individual parents for this. There are already plenty of situations where people with a lot of money have a lot of resources and have an easier time finding more. And, people who don't have as many resources have a harder time. So, unfortunately, a lot of the funding for youth mental health is for direct services, which is great, but it leaves parents out of the equation. So we've really identified this as a gap in kind of the healthcare continuum, where parents are often the gatekeepers towards services. If your kid is not getting what they need via your school district, which is pretty hit and miss around our country, unfortunately, parents are the ones who would have to, figure things out for their kids, but they're really left struggling here. I did bring up a couple of other, search engines. I don't know if I'm using the right terms. I'm not an IT person. That's why I'm looking to your group here. There are some of these, allegedly nationwide. This one's called the Child Therapy List. The best way to get help for your child. Well, guess what? It's saying there's no child psychologists in Kansas City. Okay, well, how about this LGBTQ specific engine? Also, no results here in the Kansas City area. Oh, and it's not going to let me. Will it let me get here? I wonder if some of you are familiar with the partnership that Children's Mercy made with this findhelp.org. They kind of did a white labeled version of this search for themselves over at Children's Mercy so that they can better point patients to various social service agencies around the metro, which I think has been met with great success. However, it's also lacking a bit when you go to look for youth mental health services. It'll give you a handful of ideas here, but this is certainly, not everyone that sees kids in the metro, and it doesn't give you a lot of information about, if my 5-year-old has anxiety, will these people see me? This one's actually out of Schaumburg, Illinois, even though it says it's in Kansas City. So, there's a lot of opportunity here, I feel like, to create something that would actually be useful to parents. But I'm coming to you with your ideas on how do we get this funded? Because I think I could find volunteers to potentially build this, but I would rather get buy-in from the community, have a pilot with a municipality, a hospital system, a large employer, someone who has some skin in the game that wants adults to get this kind of information. Because I want it to be, something that can be purchased by some entities so that we can keep the parents out of the equation in terms of having to pay for something like this. So that was a lot to throw at you, but that is where I am. We have this idea of this database. I already have the content for what I would want to put into it. We'd want it to be sort of a web portal that, has a companion app that parents could find this crowdsourced information and this sort of evidence-based, micro education kind of component. And I'm looking to you towards who do you think would want to purchase something like that or be in partnership. I asked Erin Deacon about kind of the local ecosystem here, and there just doesn't seem to be too much to support nonprofits in that sort of endeavor unless I tried to find something grant specific for the building portion. And then I would hope we could sell it in a self-sustaining way. So I'll open it up to questions and
That's great, Julie. Thank you so much. What sort of geography would you expect to do? Would you try to take this national ultimately, or would it try to stay more Kansas City based?
Yeah, so my partner who co-founded the Trustery with me is in the St. Louis area. And so it's definitely, we've got a Missouri thing going on. We have board members from all over the country. So once we sort of figure out what works in St. Louis and Missouri, I feel like we could replicate it across the country to the extent people were interested in that.
Okay. Do you have, tell us a little bit more about your advisory board and kind of what are those folks' backgrounds and what have they suggested so far?
Yeah, they all have lived experience with either mental health issues themselves or with their children, or they work in mental health, or they are, in politics and know that mental health is a problem in their area. They also, think that this would be a good thing to fund the organization so that we can at least pay, an executive director instead of having to rely on grant funding all the time, or fundraising more generally. And I feel like the grant funding landscape is even more in jeopardy in, January, February 2025 for mental health services, because of sort of the diversity and inclusion aspect, that seems to be under fire now from the current administration. So I'm not opposed to making this, this portal a for-profit effort if that seems to be a better fit, or if you think it's a big, potential big money maker. I don't know that it's a potential big money maker. I'm just hoping that it can generate enough revenue to sort of sustain at least, one staff person to guide things as we scale.
Right. Have you talked to technical people yet for how you would deliver this?
Yeah, I mean, I have one technical person on my board who, is happy to help with the build, and seems to think it's not going to be a big endeavor. I have another person locally here in Kansas City who's built a similar sort of matching platform for another nonprofit that would love to be able to just replicate that for this, if I get some funding. And then my neighbor across the street is Steve Fennell of Digital Drive that you might remember. So
yes, absolutely.
He's happy to act in sort of an advisory capacity as well.
Well, that's great. Great to hear about Steve again. Other thoughts from the group?
Jill,
yeah.
Jill, are you familiar with KCSAP, Kansas City Suicide Awareness and Prevention Program? It's an organization, it's a nonprofit, and part of their goal is provide a platform for people involved in all kinds of aspects of mental health, particularly suicide intervention, but not only, to get together and see how they can collaborate, share resources, etc. We're having a board meeting next month, I think next Monday, anyway, next week sometime. And I don't have your card. Did you send, John, would you send her card?
Julie, if you want to put your contact information in the chat, that would be great.
Yeah. I'll pass on your organization's name to them because you should get an invitation to the conference that will come up, but I don't know. It could be several months before the next conference like that. Okay.
Well, yeah, it's great to have.
It sounds like a perfect match for you, for people that have similar interests. Okay.
It's great to have resources. Thanks, Stan.
You're welcome.
Other thoughts from the group?
Hey, John.
Yes.
Really good stuff. Your messaging kind of at the beginning really resonated. So we have 4 kids, and we've tried to get mental health services for, behavioral health services for 1 or 2 of them over the years, and it has been a struggle, a long ordeal, to be able to get in, and certainly not able to get in on an urgent, sort of timeline. And then after establishing care, then dropping insurance and not taking new patients, and then so anyway, all of that, I think that resonates. One thought, I'm wondering if maybe this could be a collaborative opportunity with Children's Mercy and Barnes Jewish. So with with BJC West here now, St. Luke's, and obviously a heavy presence in St. Louis, and then Children's Mercy here could be a really great partner. And I think it's probably finding the right partner. And my mind's going to Rob Steele. Maybe he's their VP of Strategy and Innovation. And so maybe an introduction there. I think we'd be happy to help. I personally, or I guess personally and professionally, I think mental health is a ripe area for regional collective action. And I think everyone's kind of doing their own thing, but no one has really thought about like how do we kind of address this? How do we define it and then address it broadly? So anyway, I just wanted to plant the seed. I'd love to connect, and I try to make some contacts. We could certainly make contacts to BJC West. I don't know if we have any necessarily in St. Louis, but I know Liz Schaefer and the Digital Health KC team. I know we've been talking about keynote speakers, and at least one or two of them we've identified are BJC CIOs, and so there could be some opportunity there. But anyway, let's connect and explore that. Thanks.
Thank you.
Thanks, Dennis. Any other thoughts from the group?
Yeah, hi, Jules. This is Kat. Have you considered pitching this to a payer? They might be another source of funding that would want to see a return on investment on a service like this.
Yeah, I haven't, and I certainly could if, that seems to be an interesting direction.
Yeah, I think your direction to look toward employers, particularly anybody who's a large scale employer, certainly makes sense, but you certainly would get much even broader still reach through the payer, which makes a lot of sense too.
Do you think someone with a big local presence like GIHA or Blue Cross Blue Shield here locally is better than a bigger nationwide conglomerate to start?
You might see a little bit more uptake in the early phases from someone who's local. So a Blue KC or GIHA, someone like that might be exactly the sort of group you'd want to talk to. Also, Blue KC has an investment arm as well, where they look at new technologies and so on. So that may be an avenue as well.
Yeah. Hey, John, let me jump in too. I think Cobalt and Blue are dissociating, if I remember right.
Yes, and I'd understood though that Blue might be starting something different.
Okay.
Yeah.
Well, one other thought I just remember I should have probably led with this one, but Blue KC does fund a few grants administered by BioNexus, and we'll be probably releasing the RFP late summer, if I had to guess. One of the focus areas will be mental health. So Blue certainly has an interest in that space. So again, that we could maybe help with some intros there as well.
Oh, that's great. That's great.
May have explored this already, but some of the patient support groups like NAMI, some of those groups might, I know it's not so much on the funding side, but they might have some interesting input of resources or strategies that might be useful.
Thank you.
Evelyn, is this how does this resonate with the work that you do? Is there some other insight that you might be able to offer?
Gosh, I just think your story really hits home. I appreciate you championing it for families because on the child behavioral provider side, I think that there's just such shortages and long waits. So tools that we can have in the hands of families that, what are strategies or evidence-based things that can help support families as they're on that wait list. I think it's hard to have a search for different services because it's just such a bottleneck. So, I'd love the answer for that too. Let's be $1 million answer for sure. I just really applaud what you're doing to try to help families in that same boat.
Great, thank you. Julie, do you have other questions for us?
Yeah, well, I have one more thing that I just realized all of you might be kind of interested in. I am helping to plan a first of its kind event in South Kansas City, a wellness summit. It's either going to be, I think, 1 to 2 days. I am collaborating with Bonnie, who owns Aimwell yoga at 55th and Troost, who wants to do something for folks who've been traditionally underserved in the Kansas City area. She's affiliated with the Marlboro Community Association and works to prevent gun violence and things like that, and wanted to create a wellness event where folks could learn about all the resources that are available here in Kansas City for low cost and no cost, fitness opportunities, and everything from food to finance. And I believe it will be aimed at children as well. So we're bringing in some cool practitioners to talk with the community, do some on-site, interactive kind of exercise experiences, and have farms with food and things like that. So if that's of interest, definitely drop me an email. If you or any of the organizations that you work with want to get involved, let me know.
Well, great. Thanks so much. We have participated, KC Digital Drive has participated in a number of events. So we would probably be interested to do that. We do things like help people learn how to get connected to their patient portal, how to find means for implementing internet in their homes, particularly broadband, and so on. And maybe that would be worthwhile. I actually meet with the Marlboro people this afternoon myself. Do you have a sense of timing when this would happen?
We're looking at October.
Okay, great. Josh, please go ahead.
Yeah, just wanted to chime in here too. Just based on the previous presentation, again, very compelling, right? We always want to know if a founder or a founding team is connected to the issue they're trying to solve. So thank you for sharing this. But an immediate thought I had was in trying to build out, what is ultimately going to be the business case tied to your pitch. Getting a grasp on what the demand signal is and then what adjacent issues are there. St. Louis Business Health Coalition would definitely have a grasp at some level of the numbers that we're talking in this space for you, as far as what would be the uptake, what could be the addressable market, et cetera. So I'd be happy to facilitate an intro to one of their kind of outcomes and data leaders as well, just to help you refine that a little bit further.
That would be awesome. Thank you.
That's great, Josh. Thank you. Okay. Any other thoughts from the group? And Julie, thanks for putting your contact information in, because that will allow people to follow up with you as well. Other thoughts? Okay, well, Julie, I hope that was a little bit helpful. And as I said, with your contact information, you'll get a chance to maybe interact with people a little bit more as well. So we welcome that.
Thank you so much.
Yeah, thank you. It was, as people have said, this is really a compelling thing. It would be interesting to see this move forward. Thank you.
John, sorry, I'm
Yeah, go ahead,
late,
Deb.
but
Yeah.
Jules, this might be a long shot, but you may want to connect with someone at the Midwest Symposium for Leadership and Behavior Disorders. That is a group of educators and researchers from around the United States who works in particular with children with emotional disturbances. So they could certainly lead you into some good connections, maybe with some universities with interest around that, or business groups as well.
Thank you.
Mm-hmm. Their annual conference is in Kansas City every year too. So
who's the group again, Deb?
it's the Midwest Symposium for Leadership and Behavior Disorders.
Okay, great. Thank you.
Mm-hmm.
Okay, well, thank you so much, Julie. This has really been great. We welcome you back to the Health Innovation Team, and you're welcome anytime to join us. We're still meeting on the last Wednesday of each month and at this time, and look forward to seeing you along the way as you grow your idea and your work.
Thanks so much.
Mm-hmm. Okay, let us jump over to Jason White from Mid-America Regional Council to help us understand what's going on with care in the home. Jason?
Okay, let me see if I can make all this. Is that working for us?
It's on, there we go. Just to expand it or just hit the presentation icon and we're ready to go.
Hit presentation icon.
The one that looks like a screen on the lower right.
The lower right.
Yeah, two over from where you are. There you go.
That one?
Yep.
Oh, thank you for guiding me through this. Hey, wow, tough act to follow. That is that's a neat program you got going there. I'm gonna run through. This is a slideshow that was put together by somebody else, and John helpfully provided me ones to sort of focus on. So I'm not going to read off slides. And now I've lost count, and I don't see a count of slides. So let me give you some foundation material, and we'll bounce through the slides fairly quickly. So when you see an ambulance running around town, one of the folks in the front end is a paramedic. So paramedics are basically a 2-year trained individual. They can start IVs. They can administer all kinds of medications out of their drug box. They can administer any medication that the physician medical director of their agency allows. They've got a extraordinarily expensive heart monitor that can do almost as much as a cardiologist can do it looking at your heart. And so they're well trained. Now, their purpose in life is to run with lights and sirens and go to life-threatening emergencies. Reality is, of 100 ambulance calls, 5 or 6 they're going to break a sweat on. Most of the calls are people that are needing primary care. Now, they may perceive an emergency, and then there's a chunk of calls that aren't too interesting from that emergency vantage point, and the individual calling knew it wasn't going to be an emergency, but it's the nature of the business. But because there's a chunk of those that are primary care, you take an individual who got up in the morning one day in their younger life and they said, I want to provide health care in the home. And then we take them through paramedic training where they learn how to provide health care in the home. And then they go out and they provide health care in the home. And as I said, a small percentage of those are, oh gosh, they're really having a heart attack. They may not be with us long. I'm going to have to kick it in gear. Oh, they got run over by a dump truck. I got to do my stuff. The bulk of their calls are primary health care, where there's a chronic illness. It may be exacerbated. There may be a sudden onset of something that's not life-threatening, but it's a primary care kind of environment. So the individuals are gathering a phenomenal amount of background. Now, our instinct and our payment modalities are put them in the ambulance, take them to the hospital. So you've got individuals who are now excelling at providing health care in the home. They are clinicians, so they are comfortable in that setting, and they're using that setting in the manner of which is sort of alien to many healthcare providers that are institutionally based. So when you wander in a house and you notice that there's cigarette smoke in the air, well, I darn well know they can't lie to me when I ask them, are they a smoker, when I'm listening to their lungs. Now, if I'm curious, have on occasions, do you gander through what's in the refrigerator? Do you look at the shoebox full of medications on the kitchen table to notice the duplications of medications from different doctors? Do they take that shoebox when they go to their doc or primary care? No, probably not. But is it there for me to rummage through or have my partner rummage through to see what meds are they really have? And then you can quiz them on what they're really taking and the duplicity of all that. So home health care is, from a clinical perspective, is substantively different. I'm not even running through the damn slides, John. So is substantively different than institutional based. I'm going to find some, I want to get out of, let me find, so community paramedic functionality has been around for years. I've been in the business for more than 30 years, and there are these programs that come and go because you recognize gaps in the community. It may be Aunt Harriet is calling the ambulance an awful lot for primary care, and so let's help her with primary care so she isn't utilizing us in the emergency department and probably not getting what she needs. Or we have the example that sort of has energized this issue here in Missouri and now Kansas. It comes from the east side of the state. We had a federally qualified health clinic there. They recognized they had patients that didn't come in to check on their diabetes. Well, that means their diabetes is deteriorating and they will now become a crisis. So they asked the local ambulance service, hey, can you go knock on their door? Well, we're extraordinarily, as an industry, comfortable knocking on doors, and everybody opens their door to us. It's just in nature of our culture. And so we drove that cohort of diabetic patients up to 100% compliance because we put a primary care provider, i.e., an experienced paramedic in the home going, what are you eating? How's your diet? How are you doing on your meds? And engaging directly. Now, where that circles back to this environment is we do an awful lot of communications and technology. Now, as John will tell you, I'm as low tech as you can get on this scale, but this model works when we have in the home the ability to telehealth with a primary care provider of that individual. Maybe they don't have one and you're having to seek that out, but many of them have primary care providers. And so that telehealth environment becomes phenomenally important. So just before the pandemic, we had a huge suburban service, think Johnson County, Kansas, over on the east side. They did this model. They did a somewhat similar model around behavioral health, and they provided laptop thingers to their paramedics. And for the behavioral health patients, we diverted 20% from going to the ER to a primary care provider in mental health by scheduling. Operational problems. Those people got handed off to a community paramedic, and then the follow-up became even more successful in getting people away from an ER where behavioral health patients are sort of stacked like cordwood because it's not the environment that is conducive for providing those services, to getting them directly hooked up with the mental health care providers, doing a safe plan for the home and the environment, and then making sure they get scheduled and getting taken care of. Maybe that requires a wellness check the next day, those kinds of things. But phenomenal success in diverting those needs away from the classic healthcare environment of the ED to the. Have we gone statewide with those things? Absolutely not. So you see on this chart here, not only the telehealth visits, but the referral process. And then I'm going to drift into, so I'm going to leave this here for a moment. Here's the diversity of what we're seeing in the variety of programs here in Missouri and growing in Kansas. Depending on the need of the community is where the community paramedic program evolves. What they're doing in Osage County, Missouri is radically different than what they're doing with Kansas City, Missouri Fire Department. But the functionality is still, I've got an old gray-haired paramedic who wanted to do healthcare in the home, excelled at that, got tremendous experience doing primary health care in the home, and now we're scheduling them in a non-emergency capacity to follow up on people that are dialing 911, and we're tracking that and saying, you didn't really need the 911, all the lights and sirens response. You need better integration into primary care. Or with our primary care partners, maybe it's a clinic, maybe it's a local hospital and their primary physician staff saying, I need help dealing with these patients that aren't coming in due to transportation or cultural issues. And we can put a primary care provider in their home that is an experienced clinician, and then we engage through telehealth with that primary care provider. So that slide sort of gives you a quick background on what we're doing. Variety of things you'll notice from this particular slide is the Suboxone. We're seeing a phenomenal success So we've got a program again over on the east side that had a grant doing Suboxone follow-up for the folks that are addicted with drugs. And the local sheriff, when the grant gave out, said, "This is impressive." And he's paying for it out of his own budget. Now, I don't know if any of you know rural sheriffs, but they don't give out their money very easily. It is the ultimate endorsement of success of their particular program. I'm going to leave this slide up here for a second. So she actually provided clearance for use. In fact, the deal was as long as her cat is in one of the slides, and I don't know if they've retained through the history, but this became one of the standard gal. She has got transportation issues, mobility issues. So does she get in as often as she wants and needs to? No. So in a 12-month period of time, the number of times the local ambulance service had to respond and transport her, phenomenal. So once we started sending a community paramedic on a scheduled visit with her, and she can even call and ask for those visits, and then we communicate with her primary care provider to adjust medications and discuss. She has ER visits and emergency ambulance visits dropped phenomenally. But it's the non-emergency scheduled functionality of the community paramedic that has made that successful. So we are in, and I'm going to keep running through slides and sort of talking away from the slides, but we are in a situation where community paramedic is not found a home in the policy and payment models of CMS or state Medicaid, state policy issues. So as I was telling John at 8 o'clock this morning, our community paramedic legislation was having a hearing, and I was dealing with questions emanating from that situation. So on the Kansas side, we don't have a law yet. Don't have any regs. The stuff in Missouri is young. It's on its first rendition, and we're doing some tweaks. So from a policy perspective, who is a community paramedic? What additional training should they have when they move from being a classic running emergency calls paramedic to helping with this non-emergency functionality? This slide's a little out of date, but it gives you a quick feel on the Missouri side of activity and growth. I'm going to get back to the metro here real quickly, and I'm happy to send this to you. So from here, I'm going to talk metro area. There are 8 programs in the metro area that are up and running: Kansas City, Missouri Fire, Kansas City, Kansas Fire, Johnson County's ambulance service called MedAct, Olathe Fire, Lawrence Douglas Fire, Raytown, Independence, and in central Jackson County, which is, think, Blue Springs, Green Valley. Those agencies have all made commitments to put some of their gray-haired paramedics that have got years of experience through some additional training, and they're doing this. What they're doing is enormously different from Olathe doing some cool stuff with some of the immigrant population there and working with the school district, to Kansas City, Kansas, doing enormous amount of follow-up on the emergency ambulances running calls, and then they're reporting back going, they don't need us. They need linkage into primary care. Kansas City, Missouri lists their frequent flyers, and then they send out their community paramedics to work with them. Raytown, 98% is behavioral health and drug abuse issues. Independence, 100% behavioral health issues. There's not the commonality. I'm going to skip through the other. So we have issues both at a state, regional, and national level. We don't have data. And so part of what brought John and I together was Marlene sent me off to a policy discussion from Health Forward recently and bumped into John in the parking lot. And by the way, it was cold and he wanted to keep talking. So we're there because one of the projects we're grinding through now is, whereas we've got about 20 programs in Missouri and 4 or 5 in Kansas and another 5 getting stood up and another 3 or 4 getting stood up in Missouri, we don't have common data collection. So we have recently gone through an RFI process through one of our state EMS associations, and we're negotiating with a software firm called Health Call. That does 2 things. It provides common data collection, and then we will have common data for the policy debates. Because when we trot into Jeff City or Topeka or CMS and we tell them isolated experiences, so we've crunched the data. We've handed it off to the Medicare QIO in Missouri for one site, and we've got a 50% cost savings. We in a year's measure of that individual patient. So using a community paramedic not only keeps that nice person out of the ER, we're providing the care that they need and at a phenomenal cost savings to the Medicare, Medicaid, private health care in the system. So, but we don't have the data on a multi-site. So we're working on that now. The other cool thing that pushed health calls in front of us from a policy side was the frontline paramedics here in Kansas City, Missouri, are looking for a way to communicate with you all. So some of you all, maybe not all of you all, but they end up with patients and they need resources. So there's these informal lists of resources available because some of them may need a ramp. Some of them, the refrigerator's empty. Some of them may need a utility assistance. So they're moving into that environment that links them into community health workers. And that's part of this conversation as this builds out. But how do we do that referral process? So to complicate, and I'm going to keep running through slides just to give you flavor. So here's a couple of the clinical quality measures. If you've worked in clinics, the HEDIS measures. So these are starting to get a little dated, but where we've had community paramedics working with partnerships with federally qualified health clinics, they live with CMS, with HRSA through these HEDIS measures, and these show you the impact of putting a community paramedic in there to provide services in some of these environments. So we have been knocking on the doors of Medicaid in both states. Medicaid loves the ideas, but back to data. We've had breakthroughs, and literally the Medicaid MCOs in Missouri and Kansas, which happen to be the same companies, all three, Healthy Blue, Centene, and United. And they go by slightly different names for operational purposes. But we are in the process of solidifying contracts with Healthy Blue and Centene here on the Missouri side of the metro area at a reasonable payment rate. And because they see the benefit from the financial perspective, we're able to link patients into primary care, get them the services they need, and avoid the hospitals. Now, does that make the hospitals happy with this functionality? Yes and no. We are working extraordinarily successful with both Missouri and Kansas hospital associations, despite the fact that they recognize this is an effort to get patients what they need and not necessarily the billable services that they would find in a hospital emergency department. I'm not going to hang on the statistics long. Here, as I mentioned to you, cost savings. This was, as you can tell, a small cohort. It was one site, but we handed the data off blindly to our Medicare QIO, and they did the analysis. So it wasn't us doing the back of the napkin. And Marlene is chuckling because she knows me well, and she knows that's how I damn well do my data. I've talked about telehealth, so that is a key component of this, the telehealth component. As we talked with John, our purpose is this model evolves and stabilizes in the healthcare structure. How do we help patients become more fluent and capable? Because this model is trying to meet the patient's needs where they are, and that may require a community health worker, that may require the clinician or the community paramedic, that may, how do I link them into healthcare through telehealth services? So an idea that hasn't been explored but is ripe for the discussion. We are currently, as this slide points out, in this discussion and build out. There is no sustainable funding at this point in time, but in the next few months, absolutely. Contracts are about to move around from Healthy Blue. Next few months, Centene. We're about to break into Kansas. you will see on the federal side within the next 6 weeks legislation filed called Treatment in Place, which is payment for ambulance services that send the 911 when the cavalry arrives to chase off the bank robbers. And we don't get paid if we leave the patient at home. Bad disincentive there. But Congress has recognized that as a problem. That treatment in place legislation will be filed soon that lets us get paid to leave them at home as long as we're providing the care they need and linking them back into their primary care environment. Kiss and cousin of that is the non-scheduled functionality of the community paramedic. So attached to that legislation will be some sort of movement on community paramedic. Probably won't be a payment schedule yet. We don't have the data. It hasn't cooked well enough, but Congress is interested, and you'll see community paramedic movement on the national level and transportation to alternative destinations, which will be a big hit because we need to take people to behavioral health centers when that's necessary and not to an ER because we get paid if we take them to the ER and we don't if we take them to the BHCC. I have covered my outline, and I know you wanted me to stay at 10 or 15 minutes, and I'm going to send this to you, and so you can look at this at your own. And I'm not seeing a slide I want to hit on too much. Okay, yeah, nope, I'm not going to hit on that. I'm going to leave you with a picture of Buck. So he is the classic community paramedic you want to see show up at your door. Been doing it for 30 years in his community. And I tell you, the community paramedics in the metro all look the same, although some are women, but they've all got some age to their face. And that's what's making this thing successful. And so I'll just shut up at this slide because I think I covered the core content. Unless, John, you direct me to something you want me to jump onto that I missed that you found important. Other than that, I'm open to questions and I'll figure out how to get out of the sharing.
That's great, Jason. Thanks so much. I probably have a question or two, and I already see that we've got some from the audience as well. I guess I got very excited with this project for two reasons. First is that from a technology standpoint, and it's something that we've been promoting at Casey Digital Drive for a long time, is that there's kind of this assumption that anything in technology that's worthwhile tends to go viral. And when it goes viral, then everybody takes it up and moves it forward. But we're not finding that really in terms of being able to reach quite a number of members of the population who may, like your example, be mobility challenged or otherwise not connected to the health system. And that those folks are usually getting pretty poor health outcomes. And so we have always promoted the idea of going to where people actually are. And this is doing that. And that really makes a big difference. And so then you can apply the digital health technology underneath that to enable a high quality visit and also a high quality follow-up. From the visit perspective, you've shown us the use of telehealth or a video consultation between the home and the provider. And that just simply wouldn't happen if the paramedic was not there. Likewise, the ability to capture the data and be able to follow up on the data and make referrals from the data, just to me, is what we would call a connected health community, is that you're starting to connect the pieces in the continuum of care to move it along in a knowledge-based way, based on the data, based on the connectivity. And so I'm really impressed with that approach. And I'll let you make a comment there, and then I'll turn it over to the audience.
So it's interesting. So Marlene and I did a project a while back, and as we were trying to figure out what do we do to help train these clinicians to adapt to the more primary care role. And so the community health worker is a critical part of this whole model. And whether you train the community paramedic with that extra background, or you link them into that. But one of the things that our guys were coming out, guys and gals, saying we need a resource, and so we worked for a while on having an app so that when they were in a home, they would have a resource listing. We didn't get that done, and there's informal things, but that linkage, they are that's why they love this health calls, because they're able to send a note to whoever they've tapped into, whether it's a primary care provider at a clinic or a doc or a local resource, a social a food bank, saying, "Hey, I got an empty kitchen. What have you got stuff today?" I mean, that instant communication, and so the data was the secondary component of us getting into us. This policy geeks were going, "Yeah, we need data. Are we going to get data out of this?" And so we're hoping that this effort meets both needs. We're excited because we're at the front end. We're out pulling the money together, and it's coming together. And I think we'll have, in the next 3 or 4 months, we'll have several agencies up and going with it. The particular vendor is a smaller vendor, and he's excited about the opportunity. We're now getting calls from Florida and Indiana wanting to join our little club, because everybody sees the importance of broadly collecting data if we're going to tell our story to the policymakers to create the incentivize the funders. Although I think the corner's been turned. It's just, if you can get the damned insurance companies to agree to start paying for something, then I figure you've accomplished something, and we're there, and we're now moving into implementation. And I'm not trying to be insulting or anything. I love insurance companies. They take care of me, but they're just a tough nut to crack. I'll shut up. You've got questions.
Yeah, I'll turn it over to Sherry. Sherry had a question.
Yes, my mother had a chronic end stage disease, and we paid a monthly fee to paramedics to take her, because she was not mobile, because we were waiting on a ramp to be put in her home, and we were on the list, so we could not get her back and forth ourselves, and she was not mobile. So we paid a fee to the paramedic company monthly for those transportation. My concern or question is that a resource? She did have private insurance. She was not old enough for Medicare, and she made too much money from Medicaid. I worked with FQHCs, and I know that most times those clinics are closed and they're not open very late, particularly the things that you need, like the medical records. And they're always told, if you don't feel well or we're closed, call 911 or go to the emergency. What would the liability be for a non-medical person deciding if this is a medical issue or a clinic issue? And then we've heard from others the delay in care. So if clinics are putting you 3 weeks, 3 months out, who's to care for the limited care that's available for public health patients? How does that, where's the liability for a non-medical
So
person?
a lot to unpack there. So every part of the metro area has got a 911 response with paramedics. Not every area has got community paramedic access yet, and absolutely the community paramedic functionality is not 24/7 in those areas. So if you've got an individual that has episodic needs for transportation, I dial 911. That's what they're there for. And whereas it may be not a life-threatening emergency, they're also there to provide that transportation when there are not other alternatives. Now, will people in my industry say, well, that's not the optimal use? That's correct. We spend an awful lot of money to put an awful lot of drugs and equipment and airway devices and things, and those monitors are now 50 grand per pop, and the cots are multiple $100,000 a pop nowadays. And they're there for those small percentage, but I've family myself and been there, done that, and need assistance. They're there for those kinds of needs. Now, if you're in a community that's got a community paramedic program, the access to them is still not standardized. I'd pick up the phone and say, hey, I've got a family member and I understand you got a community paramedic program. This is absolutely a large amount of word of mouth kind of process at this stage. But that makes it happen. And then because it is so focused on filling the gap in their community, then the high likelihood is they're going to schedule an opportunity to come visit, and then they're going to know what other options may be available that I wouldn't know from a regional perspective. Liabilities way side, nothing wrong with dialing 911. They're going to show up and they're going to say, well, here's a better way to handle this, and get you started down that road if there's not a community paramedic in the area. So I would not be embarrassed about dialing 911. That resource is there for you to make sure your mother is being taken care of and transported properly. So I hope that helps.
Great, thank you. Jules?
Hey, I'm so excited about this idea, and I have two sort of things for you to think about. One, there might be a policy person on here who is more up to date than I am, but I think Medicare is no longer paying for telehealth as of March 31st under this administration. So I'm worried about that. And I wonder if there's an opportunity is the treatment in place legislation that you mentioned part of Medicaid efforts in the states, or is that a federal effort?
So you pick up Medicaid is a state and federally funded, but policy is to a large degree driven by the state. Missouri has Medicaid treatment in place. Operational reasons not used a whole lot. Kansas, we're ready to implement, but we're waiting for the federal level that is just going to impact Medicare, probably. I doubt that they're going to want to insert into the language and your local Medicaid program. It opens another can of worms from the CMS perspective. So where the legislation we had last session was purely CMS, it's being tweaked some. I haven't seen the draft, but I expect it to say just CMS for Medicare. That will energize our ability to tweak the policies for treatment in place, Missouri and Kansas, and they'll. So I think.
Well, if there is a way for you to sneak something in about your telehealth services being an important part of that, like that might be a way to get around some of it, because telehealth is always this thing, depending on the administration, that they bat around as like a fraud, waste, and abuse thing. But if you're showing these amazing cost savings and better outcomes in terms of quality, like that needs to be protected for you. So
I'm not up on the telehealth Medicare, but absolutely. So oddly enough, the congressman out of the Boot Heel of Missouri is chair of the Ways and Means Committee in Congress right now, and it's his legislation.
Oh,
and
good.
Talk
to him about that, and that you need that telehealth part protected.
I'll check with the folks that are engaged with him, because that's how we're able to be sneaking the community paramedic language into it, because he's seeing it in his district and he's excited. But I will check on the telehealth. Thank you.
The other thing that might help grease the wheels with that at the federal level is, I think this is something that would be really cool for the Office of Inspector General to write about, if not a full evaluation, like a little white paper saying like, hey, this seems to show some really cool cost savings and increase in quality. And if we extrapolate it to like the top 0.5% of our frequent flyer dual eligibles, it might, result in this kind of savings.
Love where your brain's going. So, the slide deck that I gave you, I stole from a guy on the east side of the state who's the ambulance in the FQ won the 2023 HRSA Award for Healthcare Innovation, beat out 100 other clinics and hospitals. And us little EMS guys in the world think that's pretty cool because we're this and everybody else is big. So that kind of federal recognition is going. I think that may be where the language that they're playing with may go because there's just no commonality and functionality and there's no data except this episodic stuff. And so but Congress, everything's blown up in DC lately. So
if there is still an inspector general, I would be happy to float this concept to, one of the principal deputies at the Office of Inspector General nationally. And I also know the regional folks here would be interested in something like that.
Well, regional HRSA loves it. They thumped us and we had a 4-state conference on community paramedic last August. And so you're right on. There's interest. Let me get with you offline.
Yeah.
And I put my email in the chat. So please reach out and let's set up a phone call next week.
Yeah.
That's great. That's great. Any other questions from the group?
Thank you very much for your time. I appreciate the chance and please reach out if you got comments, questions, concerns.
Okay.
This thing's evolving and at the early stage.
We did actually have another question here, and we'll take it up. Just a second, please. This is from Lisa at the Lewis and Clark Information Exchange about connecting to other groups. So you'll want to follow up on that, Jason.
Lisa, if you would email me or put your email in the chat, I would love to follow up because yes.
Yeah.
Hi, Jason. My Wi-Fi has been really iffy, so I wasn't sure I'd be able to talk, but yeah, I'll shoot you an email. I think there's some opportunity.
That's great. Thank you, Lisa. Yes, this is what I was thinking of as you described the program, Jason, is that once you've captured the data, it becomes important that it continues to move down the line, so to speak, to facilitate the continuum of care. And one of those facilitators would be the health information exchanges. So it would be great to have that kind of connection going forward. Any other thoughts from the group? I think we've really covered a lot of space here. I really value and appreciate the input from both of our speakers today. Looking forward to following up with them on various different things and welcome you all to join us again in March. And we'll be sending out an announcement about that fairly shortly. So thank you again and to our presenters and wish you all a good week. Bye now.
Thank you.
Thank you.